incredibly dry and really quite dull. So thanks, mate. so it won't be that dull, but it won't be quite exciting. So I've been asked to talk about veterans and amputee rehabilitation. So we're looking at what happens to an amputee. I suppose most of what I'm going to talk about is once they get into the NHS. But other things is talking about the Veterans Prosthetic Panel, which I'll explain what that is, and sort of general funding and general sort of access to services. Now, how do veterans differ from the average NHS population, the average NHS patient? Well, there's Steve, and he is a good example of someone who has had an injury serving for the forces. The obvious stuff is the nature of the injury. There's usually some sort of explosive device in a lot of the patients. There can be major trauma from an accident. And we see a lot of patients, especially post-2003, which are the IEDs. There's ballistics, whether it be a gunshot wound or whether it be shrapnel related. And then we have mechanical trauma, such as being run over by a tank or being knocked over by a car, or falling from great height. We have paras who have fallen from planes, doing training exercises and suffered, quite significant, severe injuries, the things you don't generally see outside of the very few cases in the NHS population. So we mustn't forget those as well as the sort of the more war-related, because there are an awful lot of injuries that are sustained during training, which lead to servicemen, men and women leaving the service. The less obvious things are the nature of the actual amputation stumps that we end up dealing with, the war vet ends up dealing with. These amputation stumps are often complicated. They have a severe amount of scarring, they have a lot of tethering, they have heterotopic ossification. They have a lot of complications that we don't see in the in the NHS population. The sort of problems with explosives that you find where you have a lot of dirty material being seeded into open wounds, and then the problems with getting those wounds to heal often leads to these complicated scars that I've just put a couple of images up there, and some of the sequelae of those, such as ulcer formation, which is just a little ulcer at the top there, but that's full skin thickness. It takes a long time to heal in scar tissue. And we often have a lot of patients with the scar tissue that they've been left at the moment. Certainly we're going through a number of patients where they're having revisions in the NHS of the surgery they had whilst they were serving, because now is the time when they can face that as a prospect. But there's also a lot of comorbidity. So not only do we have the infections, the problems with the scar tissue, the problems with the multiple injuries, is that the nature of those multiple injuries, some are spinal cord injuries, some will be multiple limb injuries, multiple limb loss, arthrodeses where the joints have to be fused because they're so damaged. So we have to manage all of these things when we're looking after the military veterans. I put psychology in slightly in bold there, because that is the other thing, is that the average duration between onset of an incident and the presentation of PTSD or PTSS is about 10 years. So these are sort of the situations where you find the presentation. Headley Court found that they had very little in the way of symptoms of PTSD when the veterans were there. What we're seeing and what we've expected is that we're seeing these symptoms arrive much later on. And I'm having patients now who are sort of 5, 8, 10 years later after the incident, their index incident, coming to me now and saying, what stuff you're talking about? Well, maybe now I'll see the psychologist. Maybe I want to talk about it a little bit more. And this is one thing. Headley initially were saying, well, we don't have this issue. It maybe is more of an NHS issue, but it wasn't. It's more that it wasn't coming out at that point because it was just too early in the course of any veteran dealing with those sort of problems. Other issues, pain. Pain is a massive issue for any amputee, and we have a number of patients who've been injured, not amputees, or some now amputees, who've been left with things like chronic called complex regional pain syndrome, sorry, not complex regional pain syndrome, and other neurogenic pains, which are very difficult to deal with, and that's certainly something we've found more recently, is that we're having quite a number of vets coming through asking for amputations within the NHS for painful conditions that they've been discharged from the army with, and it was expected that they would be able to manage their lives with this pain, but have not been able to manage their lives. I think in the last 2 years, I think we've had 4 patients who've gone through that process and are now amputees because of these painful conditions. How long does rehab take? There's sort of how long is a piece of string type thing. I mean, this is the injury occurred in the battlefield, let us say, or it could be in the training ground, let us say, and there's minutes to hours before a field hospital or a local hospital, and then there's a transfer back to England or to QE where the surgery is done, and then down to DMRC where the rehabilitation, and that can last, you know, months for some patients, but not many. Most have been through Headley and have been there for years. I don't mean like 10, 20 years, I mean sort of 2, 3 years, until they've reached a point where they feel there's plateau, they've plateaued in their rehabilitation. And then they come into the NHS. I'll describe what services there are for them in the NHS, and obviously they'll be with us for the rest of their lives, unless they move to another country. Now, it was recognised back in around, yes, about 2011, I think it was 2010, and it was Blesma was one of the big groups, Royal British Legion, another one, these groups were pushing the government to say, we don't think that our veterans are being looked after, and the veterans are worried about, or serving, we're worried about discharge into the NHS. And was the NHS going to be able to maintain the same standards of care, the very high standards of care, I might add, that Headley Court had been providing and had been administering? And I think this is also, from the veterans' perspective, something which was quite comparative with the way that the American Veteran Service is set up, and the way that their Walter Reed was funded, and how much infrastructure there was behind them. They have their own separate veterans hospitals, for example, over there. And so Dr. Murison, who was now serving MP at the time, and I think still is, was charged to do a report to work out how to enhance the NHS service to meet the demands of the veterans who had very different demands. They are a different group of patients in many respects, and I'll find that a bit later on. So he came up with a strategy and a bunch of recommendations. And the recommendations, I've listed more here, but I'm not going to go through them all with you. But there are 11 recommendations, of which most of them were taken up. Some of them weren't taken up, and some of them haven't really come into fruition. For example, the involvement of NICE hasn't come into fruition. But a lot of the other recommendations, such as accessing the NHS mainstream provision through a DSE of their choice, through refining the transition protocol, ensuring that we get the information that we need for the veteran once they transfer over into the NHS, and having a defined pathway. Some things are still ongoing, like the relocation of the DMRC. So there are a lot of these recommendations that were made, and the basis of those were to come up with a certain number of centres, which, when it was implemented, were with 9 centres. Now, the centres across the country. I work in one centre. That's that centre, and this is what a lot of these are the list of healthcare professionals you'll find in most of the centres in the UK, and most centre and all of the enhanced centres, all 9 of them. So it's a big team, and you can see how many NHS patients we've got there. Nearly 2,000 amputees, 11,000 orthotic patients, 25,000 wheelchair patients. So it's a big team looking after a large number of patients. Now, this was the information. Admittedly, this is a couple of years old. I haven't had a chance to get the latest figures, but this was the sort of the numbers of amputees that were thought to have come out of that were involved with Blesma at the time of finding this information out. which is about, like I say, 2 years ago. You can see 19 triple amputees, 146 double amputees, 611 single amputees. And they did tend to be, the amputees tended to view themselves and also be viewed by charities, for example, at the time, previously, between sort of pre-2003 and post-2003. So initially, for example, Health for Heroes was set up purely for the post-2003 group of patients, and now any of them can access that service, but initially that's how it was. And the being able to access Headley Court, for example, even now, if you want to access Headley Court to go to the complex review planning there, you have to have been through Headley Court. So there is still some of that viewpoint still ongoing. And the numbers of patients is low. I mean, you saw how many patients Preston's got. It's not the biggest centre by a long way. We're about the 7th biggest centre in the UK, and there's about 35 centres in the UK. But you can see the number of vets are different. There are a different number of vets to relative to the different centres that I can get the figures for. And we're not the highest either. Plymouth is that, well, certainly was the highest. But there are different numbers of veterans in different centres, and it doesn't follow the size of the centre for the NHS population has an equally large number of veterans. It hasn't seemed to work that way at all in all respects. Now, one of the big things that came out of Dr. Murison's work was that there was going to be not just an enhancement of certain centres, but a way of all centres being able to access a large chunk of money to be able to get the kit that the ex-serviceman needed, the veteran needed. And I might add that these are veterans and ex-servicemen and women who have amputations for service attributable injuries. So if they're an ex-serviceman and they have an amputation for, say, diabetes out of service, then they don't have access to the enhanced aspects of this care, just to make that clear. It's for guys and girls who have been injured in service and which has led to an amputation. So the panel was set up to ensure funding for any centre that the veteran chose to go to. They don't have to go to an enhanced centre. They can go to any centre, and that centre can apply for funding within England. The devolved administrations have their own ways of dealing with things. So the Veteran Prosthetic Panel is a panel that meets once a month. You apply for the funding. It's not retrospective funding, so you're expected to provide the evidence and trial data of what it is you're asking for, and the panel meets, and they go through each individual case on there and approve it or decline it or ask for further information, one of those three. And on that you have commissioners, clinicians, representatives from various charities. You had our forces representatives and members from the DOH, representatives from the DOH as well. And everything is audited, which is why I've got various slides that I've shown you. Those are the 9 centres which concluded in a tender in 2013, which concluded, and those are the 9 centres that were chosen. And they roughly correspond to, there's one somewhere near, that the country's effectively divided into 9, and this is the location there. The most controversial, I guess, would be Carlisle, which is covering North Yorkshire as well. Now, how does Preston perform? We're pretty proactive. So this is the number of applications to the Veterans Prosthetic Panel. You can see Preston is that big sort of tall one at the end. We're very proactive with the veterans to ensure they get the care they need, and I think a lot of other places are also extremely proactive. One of the reasons that we were able to be proactive is that we were able to find our veterans very easily, not on a paper system, but we have a computerised system, which, believe it or not all of the NHS is computerised, and there were still areas and centres working on paper notes 2, 3, 4 years ago. And so for us, it was easy to find the active veterans, to be able to review them on a regular basis, but we also had a different way of practicing. And partly that was because we had the Blesma home, and the the Blesma home. Blesma is the British Limb-Sex Servicemen Association, and they had a home for the elderly, and well, anybody could stay there who's a member of Blesma, up in Blackpool. So we already had quite a number, about 20 Blesma patients who would be coming down to us. So we already had a slightly different way of dealing with veterans anyway, because they are complicated and complex patients. And we had to also develop a new service model, because a lot of patients were returning into the NHS. So we basically extended our policy of, for example, 2 prosthetists for each veteran, 3 if they're an upper limb and a lower limb patient. Dedicated veterans administration team so that the people knew who to contact, a dedicated number for the veterans to contact. Ways of basically making the communication easier with us so that we could find out what's going on, so we could act proactively and react quickly. We also discussed the war veterans every meeting of our quarterly meeting, of our 2 weekly meetings. And we review all safety case notes as well every quarter. Now, how does the statistics for how veterans use this service differ from the NHS patients? Well, the table above, I spent all yesterday and last night crunching some data, only about 5,000 lines of it, just so I could give you some idea of how they differ. How do veterans differ? And then we'll go on to why do they differ. Well, how do they differ? So if we look at the total number of appointments, you can see that's the second line down, and each column represents a year of midpoint of year to the next midpoint to the next year, 40 to 50, 50 to 16, and 16 to yesterday morning. And those are the number of appointments that we've had. And the average number of appointments per veteran in that year was 26 in 14-15, 25 in 15-16, and 19 in 16-17. That's the average number of appointments. And you can see the range there. One veteran last year, he came to the unit 154 times. You have, but the medium is 21, 16, 13. You can read those. And there's a significant number of failed to attends and unable to attend. But if you look at that line of the number of patients, so we're talking 1,500 appointments for 54 patients in that first year. So it was generating a lot of work, which is why we had already assessed. So we had asked for, as part of becoming an enhanced centre, we'd asked for more staff. I'll go through that in a little bit. But the amount that the veterans use, they have a lot greater need of our service in many respects than the average NHS patient. That's just to give you an idea of the ratio of numbers of NHS patients who are not veterans who service attributable injuries, and the number that is. The red is, and the blue is NHS patients who are not veterans with service attributable injuries. So there's a big difference. When we look at the number of appointments, we see that, I said to you before, the light blue, the tall columns are the average number of appointments that the war vets had. The smaller column is the average number of appointments that a non-veteran NHS patient would have. So the difference is quite marked between the average NHS cohort and the average war veteran. And I would say also that the war veterans, because we have got some elderly patients in our catchment area, some of our war veterans are in their 80s. So it's not as if you can say that this is only going to be due to the fact that a lot of the NHS non-veteran patients are going to be elderly. It's not. It isn't just that, and you'll see why in a bit. Veterans, their appointments as a percentage of all our appointments, it was 10% 3 years ago. A couple of years ago, it was around 10%, and now it's about 8%. Now, I think that in many respects is the fact that when patients transitioned out of Headley, they'd often not been seen by a prosthetist for several months. We often had to remake sockets and manage the changes that patients experience when they leave the military and their lifestyle changes, and often that is reflected in the fact that we need to make new sockets and things. So that I think is why, but we seem to be on a relatively even keel now, and we expect that to continue. When looking at are they a different group in terms of failing to attend appointments or being unable to attend appointments? And if you look at the groups, there's no significant difference between vets. It's not as if they are turning up for not turning up for appointments when they've scheduled them any more than anybody else. It's very much the same information. Now, what has that led to? What's that investment, that access to the service, and then becoming an enhanced centre? What has that meant for in improving patients? And it's improving patients' experience and patients that maintain their activities by innovations such as utilising the by-design socket, which is a different way of holding the socket. It's 2 or 3 years old now, but it's a different way of managing the socket to give a patient a better range of movement and better control of their artificial limb. That was one of our war vets there. He was the first person that we trialled this technology on when they came over to train us from the States. Using modular socket systems so that we can provide the sockets rapidly for patients. And one benefit to the NHS patients is that as we've started using this, we've recognised also that it can be cost effective to use them with the NHS patients. So now we use, for example, those two things as equally as we would for veterans, as we would for the NHS patients, or vice versa, if you want to look at it. And then we looked to improve the infrastructure. And one of the things that we wanted to do was to be able to get a service which was familiar to the guys coming into our service of where they underwent their rehab in Headley Court. So when the announcement was made, which was when we went for some discussions down in Headley Court, I was able to note down and discuss with the different healthcare professionals, physios, OTs, orthotists, prosthetists, what kit we should be getting, what should we be looking at to try and emulate what Headley Court do, so that it's familiar stuff. And there's some enhancement. The prosthetists felt that there's certain things which would be beneficial to us, so there's some technology to replace existing stuff we had. There was things like having some gait analysis, so we can analyse the patient, the veteran's ability to walk, and improve their balance and so forth. Gym equipment, they're familiar with this stuff. This is the stuff that they have in Headley Court. Looking at developing our own gymnasium with equipment, techno gym, which is the same stuff. These are the same machines, almost exactly in some regards. And then before we purchased this, we went and had a small focus group with some of the war vets of what they wanted to do, because it's all very well me saying what I wanted based on what the guys recommended down there, but what did the actual veterans find worked for them? And some of the things, the machines like that big one with the pulleys you can see there in the foreground on the left there, that wasn't in Headley Court, but it's one of the things that a few war vets have said in the focus group, no, this is a piece of kit which will be useful for us. And there's a pinch of an anti-gravity treadmill, which is something they had down there, which is able to get people walking. And it's been extremely useful for us because there have been a number of, like I say, ex-servicemen with service attributable injuries, which we've ended up having actually and then undergone amputation. So we've been able to put them through a very similar program to Headley Court, not as frequently. We do not have the same staffing levels that Headley Court have. Our prosthetists will have 200 patients on their books, not 4 or 5 on their books. So there's no way we're going to be able to emulate those sort of levels of service. But it seems to work very well. Patients get back to, or at least have been doing very well with their rehab. We did ask for some personnel as part of the enhancement. 2 prosthetists, 1 senior prosthetist and 1 junior prosthetist. And 2 technicians, a physiotherapist, physical training instructor, and increased admin time. So we were wanting to prepare for and ensure we had the right number of personnel so the veterans weren't left waiting for things to be done, or as little as possible. With the aim that we'd hopefully improve the mobility of patients, maintain their level of mobility, maintain their level of exercise, and support their employment, supporting their sporting endeavours, so whether that be Jonathan Butterworth, who is a Paralympic gold medalist in Rio. We have a few patients going to the Invictus Games, and then we have a few guys who have moved forward since things like being physical training instructors, golf. Well, the UK's first amputee, who is a golfing instructor, is another one of our patients. So being able to sort of progress and maintain patients on what they wish to do. And I say veterans are a slightly different breed to our standard NHS patients. I say they want to do more. They're wanting to be out there and to be able to do everything they did before. They want to get back to that, whether it be running as a hobby, or whether it be running to demonstrate that Andy Grant, and Andy Grant he just broke the world record for 10k there for a single lower limb amputee in I think 37:17, which anyone who runs out there is. Anyone who runs out there will know that 37 anything is a damn good time, and 37:17 is certainly a time I've never seen anything close to within about 15 minutes. So it's trying to keep these guys doing what they want to do, engaging so they can engage in their family life. And yes, the sort of kit they have is impressive. They have access to the computer microprocessor controlled knees like the Genium, which costs in excess of sort of £40,000 for just a knee unit, and that used to be completely different to NHS provision. But even now we don't have that. Now the NHS we can provide microprocessor controlled knees to the NHS patients as a matter of course for the right patient. So I think when we've been managing this group as a health service, it has led to improvements also in the NHS in general. I think there's been a positive experience, I think, not just for those of us who are working in there, it's been very positive, but also for the NHS on the whole. Because all those things that have enhanced our service, whether it be the gym, the physio equipment, or the gait lab, or the casting tools and so forth, all of those things are used for NHS patients as well. So we have we were able to also embellish that service. I think that's probably about it. Any questions from anybody? Or anything I haven't covered?
So any questions from the floor for Fergus? I think you've had a lucky escape. I have a question as well. With Headley Court moving to Loughborough, Stamford Hall, what can the NHS learn from defence medicine, and what can defence medicine learn from the NHS? Because that's obviously how it will be at Stamford Hall. What are your views on that?
Well, probably not the right man to ask, because I'm not sure which are all services going to be moving and how those services are going to be managed. Certainly, what we've learned from Headley Court, there's been an awful lot of knowledge that's come about ballistic injuries and IED injuries. The way they've managed some of the complex stumps, has been a learning point for us in the NHS. I think when it comes to the two services, Headley Court is massively, it's a much more expensive service than anything in the NHS. And what they do there is absolutely right for that group of patients. I think for NHS patients, most NHS patients wouldn't fit into that service. With the complex review clinics that are down in Headley Court, if those were expanded, also the amount, if you could refer NHS patients, the complex NHS patients, from the locale into the new DMRC, and that would be a good thing to be able to do for a lot of centres around the country, including ours.
Thank you, Fergus.